And the program is Ultimate Health on Joy 99.7 FM. Listen every Sunday, 2:05. We come to you by His kind mercies. Thanks for making it a date. We've been a bit down. Parted ways with our real boss, Elvis Koku Kwashi, but not forever. We'll take this to strengthen all of us in the Kwashi family as well, the MGL family. God definitely makes a way.
Joy 99.7 FM.
You know it's another OPK classic.
Slight musical mix up, huh? I thought I had Made Away by Koda featuring Irama, but this is an instrumental by King Promise called Ayeko. So we'll go straight into the business of the day. Of late, we've heard from our medical experts that we've been neglecting many of the non-communicable diseases. Today we talk about chronic kidney disease as part of our extended feature on the 60th anniversary of the University of Ghana Medical School. And I have one of the fruits of the school, Dr. Vincent Boima. He's a senior lecturer and a nephrologist, head of the nephrology unit of the Department of Medicine and Therapeutics at the Kolebu Teaching Hospital. He joins me this afternoon. We're going to be learning about kidney disease. More common than you think. Some of the statistics are staggering. But more importantly, we'll be focusing on the shift, if I can say, in the profile. We're getting younger and younger cases of renal complications. What accounts for this? What is kidney disease? What are its curious relationships with diabetes, hypertension? All that and more. You can join us on WhatsApp 055 11 11 997. We're live on Facebook and YouTube. We're talking about young but failing kidneys. And we continue the series as part of our celebration of the 60th anniversary of the University of Ghana Medical School. Dr. Boima, great to have you in the studio.
Thank you, Dr. Nortey Dua.
And you're so resplendent in your anniversary cloth, and I haven't set up mine and sold it yet. So this is lovely. It's lovely shirt you're wearing.
Yeah, thank you very much. I believe it's the school's anniversary, 60 years down the line.
Yeah.
And we are all trying to live in that solidarity to celebrate this anniversary,
right?
60 years of churning out doctors who should be serving society, who should be caring for the health of the people,
right,
in Ghana.
Okay, school was set up. At least the plan started in 1919, and the first batch, I believe, was came out in 62. No, the first batch was in 62. About 51 doctors. I believe, correct me if I'm wrong, you are the year mate of Dr. Jifa Day we had last week.
Yeah.
So that makes you what, the 2002 year group?
2002 year group.
Right.
Yes.
And she said due to some strike and other things, you straddled 2002, 2003. Right. But we're glad to have you. Let me start by, getting you to clarify for my listeners, who or what is a nephrologist?
A nephrologist is a doctor who specializes in diseases of the kidney. So nephro, you literally meaning kidney, really.
Right.
So when you learn about kidney disease and care for people who have kidney disease, then you are called a nephrologist.
Okay. Right. So that's your area of specialty.
Yes.
Right. So you completed and then you went for further training
Yes.
and specialization here in Ghana?
So I had my primary education here in Ghana from University of Ghana Medical School, and then I joined the postgraduate program after I passed the primaries in the West African College of Physicians and Surgeons, where I did my residency. After my membership, I went to Cape Town, South Africa, to specialize in nephrology.
Right.
And came back in 2010, and then did my fellowship again in the West African College of Physicians and Surgeons.
Wow.
Yes.
And you currently head the nephrology unit of the Department of Medicine and Therapeutics.
Yes.
Wow.
That's
That's a long journey. What's significant for me and which I want to share with my listeners is you came back to Ghana to serve. And you've been here since.
Yes.
Wow. Okay. Right. Thumbs up to you, your year group, and of course to the University of Ghana Medical School. Coming back to the subject for discussion, young but failing kidneys. So, kidney function, kidney disease is your area of specialty. And let's just share with our listeners what's the concern or the significance and why this topic?
So thank you very much once again. The significance of this topic is really significant because most of our patients afflicted by kidney disease, chronic kidney disease for that matter, are really very young, between the ages of 20 to 50 years. When you go to high-income countries, most of the patients who are on dialysis or have kidney disease are literally more than 60 years of age.
Right.
Meaning that we are developing this kidney disease 20 to 30 years younger than they would develop it.
Wow.
So our patient population is young, and really that's concerning because you can see clearly that this really form the youth of our society.
Right.
We are the economically productive group of society,
Right.
who really needs to be out there working for the country and are being afflicted by this disease. So it's a concern, and really it means something must be done. Whatever the causes should be found,
Right.
so that these people could stay out there working and helping to develop Mother Ghana rather than being afflicted and taken away by disease.
Right. So you're hearing from Dr. Vincent Boima, consultant nephrologist, right, with the Department of Medicine and Therapeutics nephrology unit, right? He specializes in kidney disease. He's telling us that the chunk of our kidney cases are within the ages or the range of 20 to 50. Productive years. You may have heard that Africa, indeed Ghana being part of Africa, should be capitalizing on and harnessing what we call the demographic dividend. We have young populations, but gradually over time, we're losing that advantage. And this is an important concern. Young persons with significant kidney disease. Now let's come back to kidney disease. What's the kidney, Dr. Boima?
So the kidneys are more or less two bean-shaped organs located in the abdomen.
Right.
And they serve many functions, including, literally, let's say they wash your blood. They cleanse your blood of filth and toxin.
Right.
So when you eat and then your body works on the food, the waste is removed literally by the kidney. So let's say the kidney is not a zoom line of the body, cleansing the body.
Okay.
So remove all kinds of toxic from waste products of metabolism, and then it's peed out or cleared in the urine. That's one of its functions.
Right.
It's also make sure that your body is in a state of normal water balance. So excessive water may be removed through the urine. Other metabolic works of the kidney include maintaining acid-base balance, so that the acid product from your food, other metabolic works in the body doesn't accumulate in the body to cause problems. So it maintains that balance. It ensures that the electrolytes, potassium, sodium, other chemicals, calcium, magnesium are maintained within the right balance in the body. also produces hormones or chemical substances that helps to produce the red cells in the body,
Right.
and many other functions. So when we say the kidneys have failed, it means they are failing to serve these functions.
Right. Okay. So you're learning that the kidney is a very important organ. We have two of them, and they serve to filter, cleanse our blood, keep our system in good, functional, healthy, working balance, right? And they help in the production of the red blood cells, also very critical and vital. So this is a very important organ. As part of Ghana Month, I was reading, I'm yet to get the Ghana name, but I read that the Akan or tree name is Sawa. And interestingly, I found out that in Ewe or Ewe, it is called Aiku. Am I right, Doc?
I think so.
Yeah.
I think I've heard that before.
but
It's called Aiku, yes.
Where do you come from?
I come from the Volta region.
Oh, you have failed.
I feel, yes, I understand that.
My listeners will share with us. If you know the indigenous names for the kidney, help us focus, zone in on the topic, right? I've provided what I've researched to be the Akan, Sawa, or Sa, and then the Ewe is Ayiku,
yes.
right? And I actually was practicing an Ewe phrase with Ayiku in it, but I couldn't quite wrap my tongue around it, right? Okay, so you're with us on Joy 99.7 FM. We're learning about the kidney, what it does, and more importantly and essentially, we're talking about kidney disease. So, Doc, having explained what the kidney is supposed to do, filter our blood, clear waste products, right, and excrete the bulk of this through our urine. Right. So this is a very important function. When do we say there is kidney disease and when is it chronic?
Okay. So thank you very much. In order to put this in context,
Right.
let's actually try to distinguish between two common injuries that the kidney can suffer.
Okay.
So an acute injury
Right.
and a chronic injury.
Okay.
The acute one occurs abruptly within a short time, in hours to days.
All right.
And may lead to accumulation of all these toxins that we talked about.
Okay.
And usually it's due to short-term illnesses, maybe diarrhea, vomiting, typhoid, what we call typhoid,
Okay.
heart disease, liver disease, drugs that you may have taken in, other systemic diseases, autoimmune disease, etc. But once these underlying problems are corrected or treated, the acute kidney injury usually would recover.
So this is reversible.
This one is reversible.
Okay.
However, let me be quick to say that when you develop an acute kidney injury, you are at risk of a future chronic kidney disease, which I would be defining now.
Okay.
So chronic kidney disease is not the same as acute. So when you have a kidney injury which recovers, it's most likely an acute kidney injury,
Okay.
which had recovered. Then the other one is a chronic kidney disease. This one is a type of chronic kidney disease that has been going on for some time. So your doctors will need, for instance, your kidney function over the next 3 months or more to see whether the kidney dysfunction
Right.
had been persistent for this period.
Okay.
They will also need a scan to look at the appearance of the kidney, the sizes of the kidney. If the size has reduced and appearance is somehow blurred, it may suggest that it's a chronic kidney disease.
Right.
If the dysfunction I mentioned earlier on has been persistent for 3 months or more,
Right.
it signifies chronicity or chronic kidney disease.
Okay.
Or perhaps there had been protein in the urine, or maybe blood in the urine as well. Again, 3 months or more is also a sign of chronic kidney disease.
Okay.
So we need this and the duration to be able to tell whether the person has chronic kidney disease or not. Some people, a lot of people make mistakes. They do only just one lab.
Right.
And then looking at that lab, they say, oh, I have chronic kidney disease. They are running all over the place. But it may not be chronic kidney disease. It may just be an acute or transient change in the kidney function,
Okay.
which would correct. So you
Okay.
need to see a doctor or somebody who can put that particular test in context, for you.
All right. Great. That's why I've yanked Dr. Vincent Boyma into the studio, because you cannot put it in context. We need to understand the critical issues and the description and indeed the conclusive diagnosis of kidney disease and then chronic kidney disease. He's talked about the short-term, reversible, acute kidney disease or compromised kidney function, right? And those ones are due to illness and other things, and they are short-term and reversible or treatable. Now, if this persists for longer than 3 months within a context of other features and presentations, then the specialist with the requisite training and expertise can now determine whether you have chronic kidney disease, right? If you have any questions or concerns, you can share with us on Ultimate Health. We're live on Facebook and YouTube, and also our WhatsApp is 055 11 11 997. 055 11 11 997. The numbers and the profile of the numbers for kidney disease are changing, and that's what Dr. Boima emphasized and highlighted. We're seeing younger people in our parts of the world. If you look at the description for other parts of the world, you'll see that it is typically seen in older persons. He's talking about the productive age group here in Ghana, and I've read a couple of studies, Dr. Boima. I saw one by Tano and Co. Tano, the late Jake Plandrule and Co. And they're suggesting various numbers for the prevalence, right, of kidney disease in our part of the world. Can we speak to that? How common is it and how prevalent is it in our part of the world?
Yeah. So globally, the prevalence rate is really about 10%. But in sub-Saharan Africa, there was a meta-analysis or systematic review which put that figure around 13.9%. In Ghana, from Tano et al., as you said, it's our 13.1%. In another study from another doctor in Kumasi as well, our 13.3%.
Right.
However, it's said that the actual burden in our sub-region may actually be 3 to 4 times that of the global figure, because all these figures I've given you for Ghana and sub-Saharan Africa may be understated in the sense that we have poor record keeping. We don't have a good data registries. So whatever figures we may be getting right now may be out of poor data records which are incorrect, and therefore the burden may be actually higher than these figures that you are
But definitely and emphatically from what you said, despite this maybe underreporting or artifacts of sampling, we do know that what you're reporting or what you're referring to with regard to African data and indeed Ghanaian data is higher than what you're seeing for the world average. And that is serious, right? And that is significant. Okay. Let's zone in a bit now. So we are getting higher numbers. We're getting younger persons. Can we talk with regard or speak to risk factors? What is likely to compromise a person's renal or kidney functioning? Who is getting it more? I've seen some stuff about gender and age and other. Are there risk factors we can pin down?
Yes. So globally, I think the commonest risk factor is still diabetes.
Okay.
And then hypertension, other vascular diseases. In fact, there is also inflammation in the kidney, which you call glomerulonephritis.
Okay.
And there are different types of these glomerular diseases, which maybe is not for this forum, so we'll not go into those details. There are cystic kidney diseases, one of which is what we call the polycystic kidney disease. And that one is a familial kind of kidney disease.
Okay.
So it's
runs in families.
It runs in families. Okay. So you may get it from the family line. And there are exposures to environmental toxins, like maybe use of drugs such as NSAIDs, so diclofenac, naproxen, paroxycam, Indosid, etc., which are drugs that when you get exposed to, you can or potentially at risk of developing
this. This is the abuse of these NSAIDs.
Yes, can be a factor as well. And there are infections, hepatitis B, hepatitis C, syphilis, HIV, which really sub-Saharan Africa is the epicenter. So that also may be adding or increasing the numbers of kidney disease, because now that they are on heart or treatment, they are living longer and may probably at risk of developing kidney disease. So it may be adding to the numbers that we are seeing now. Use of recreational drugs like heroin, for instance, is also a risk factor. Other heavy metals exposures are also known risk factors. In our part of the world, in Africa, the studies have shown so far the commonest risk factor may be hypertension. Right. But diabetes is rising, so definitely one is probably contributing significantly to this number. Okay. And then also, so it's diabetes, hypertension, diabetes, and glomerulonephritis, like I mentioned earlier on in our part of the world. Okay. But there's a chunk of people who we have actually labeled as CKD of unknown, chronic kidney disease of unknown origin. From our database right now, you can't determine the cause of the kidney disease in this group of people.
Okay.
And mostly it's because a lot of these people tend to present very late, at the late stages of this disease.
Okay.
So where diagnostic workups into details become difficult to really ascertain what the cause may be.
Right.
However, looking at this same database, like I told you earlier on, our patients are very young. The mean age, in fact, from this database is about 41 years of age.
Whoa.
And it's almost about 62% of them are between the ages of 20 to 60 years, really still very young in this group.
Okay.
So looking at this group, and looking at some of the publications from our colleagues in Kumasi, for instance, they have attributed this to this inflammation in the kidney, which may have been due to infections in the past, like Hep B, Hep C, some bacterial infection causing inflammation in the kidney, which may have been treated and lost to follow-up or may have not been detected. So over time, they have progressed to developing kidney disease. The other thing is it also still due to lifestyle? Migration-related lifestyles in our part of the world. Eating of fast food, increased salt intake, lack of...
So where we felt we have developed, we have arrived. We've actually taken on the disease burden of those parts of the world.
And therefore adding to the numbers.
Right.
And so the other aspect which we need to look at also very important and carefully is genetic predisposition. Genes have been isolated in blacks, which seem to predispose them to developing kidney disease. And recently, ApoL1 gene in African Americans have been found in high frequencies among these population of people, which increases their risk of developing kidney disease. And faculty from the University of Ghana Medical School have been studying this in the sub-region, from Ghana, Nigeria, especially. We have found that there's a high frequency of this gene among our population, almost up to 30%. So that it means that already by virtue of this genetic predisposition, we are already at risk.
We have a latent diathesis for this.
Exactly.
Right. Some software in our programming, and we did DNA recently, right?
Exactly.
Is predisposing us to these things. And then we are loading on some of these secondary factors.
Perfect. So at the end of the day, it's not only the genes per se, but it's an interaction between the gene probably and the environmental factors. Some of which may be the toxins, the heavy metals. Look at the galamsey, for instance. They are polluting our water body with arsenic, mercury. And these have been linked to kidney disease, chronic kidney disease as well. Drinking of underground water, which are all polluted, etc. In fact, in some publications, some in India, for instance, air pollution alone have been linked to development of chronic kidney disease. Right.
This is a big problem. It's 25 minutes past the hour of 2 on Joy 99.7 FM. The program is Ultimate Health, your ultimate guide to healthy living. Listen every Sunday, 2:05. We're live with all the up-to-date, accurate, precise, unassailable health information. Today we're talking about kidneys. Yes, young but failing kidneys. Sounds strange, sounds ironic, but from my expert in the studio, Dr. Vincent Boima, head of nephrology unit at the Department of Medicine and Therapeutics, Kolebu Teaching Hospital. He's a senior lecturer and a nephrologist, and we're having him kind courtesy of the University of Ghana Medical School's 60th anniversary series. We're going through a range of specialties and issues that should be important and critical for discussion, and that's why we brought him today as part of the celebration. Should I say gratitude also to Multimedia Ghana Limited for giving us this platform and supporting the 60th anniversary. If you have any questions, concerns, if you're an alumni of the medical school, join us. WhatsApp 055 11 997. We're live on Facebook, and shortly I will activate those phone lines so that you can talk directly to Dr. Vincent Boima. Doc, so looking at all these factors, and part of my reading also unearthed or revealed the fact that many people are walking around with undiagnosed, unknown, compromised renal or kidney functioning.
Absolutely.
Many people don't know they are diabetic. Many people don't know they are hypertensive. And these are critical should I say, risk factors that you've just shared with us, right? So are we capturing everybody, for example, in the regions that galamsey is prevalent and the water pollution and other things, the toxic metals and other things you talk about? we're not able to picture or pick up these. What I read from advanced or Western countries on kidney disease is that the access to actual assessment, diagnosis, investigation, treatment, and management is way below what it should be. I have you in the studio as a specialist of several years standing. How many of you are there? Looking at the numbers we're talking about, 13 point something % of the population, as I saw in Tano, Planjrul and Co. Right? I've seen another one earlier by, I think, Dr. Charlotte Osafo, where they looked at the prevalence of the numbers in populations of persons with hypertension, diabetes, or both. And theirs were through the roof. I saw 40-something % and so on.
That's a high-risk population.
High-risk population.
Yes.
So how many of such skilled, qualified, and experienced personnel and specialists as you do we have to deal with this big problem?
We are limited, but we are improving. So maybe between 10 to 12 nephrologists, both children and adult nephrologists, mostly in Accra and Kumasi, and that's really where you find them. You don't find them anywhere else. That's a problem.
My goodness.
So we are actually improving on the numbers gradually. The Ghana College of Physicians and Surgeons has a nephrology program.
Okay.
People can enroll and train as nephrologists.
All right.
West African College of Physicians, again, we have a nephrology program where they can enroll and train and become nephrologists. We have had graduates from these institutions already.
Okay.
We also have collaboration with sister centers supported by International Society for Nephrology, where people go and train and come back, or those in the local program can rotate through such places and come back. So far, within the past at least 5 to 10 years, at least we've produced at least 5 to 6 more people through these institutions, and we are still in the process of producing more nephrologists.
All right.
Yes.
You sound very optimistic. I'm a bit staggered by the statistics, but we are moving slowly but surely. Right. So GKA from East Legon sends me Flufla for the Ga translation or Ga name for the kidneys. I thought Flufla was lungs. Correct me if I'm wrong, but thanks for sharing that. Let me go through a couple of your messages. Elliot in Sawam says, good afternoon. The Ewe name is Ayiku, as you rightly said. Akpesia, Elliot. My guest didn't want to or didn't know the name. We are educating him. He's educating us. Please, Doc, how true is it that intake of coffee can cause kidney disease? This is from Dagati in Petroleum or DC Petroleum. Ultimate Health, this one says, Chris Ambrose from Dabala Junction. Nortey, you are right. Kidney is Aiku Akpesia. Because it is bean shaped. All right. Okay. I'm learning. I'm growing. This one says, oops, a lot of scrolling down. Fast. All right. You are the best. Okay. Thank you. After scrolling down, that's it. Castro Odomena. What's that one? I can't understand. Menawara. Okay. Miniwara or something, I guess. This one says, Doc, so happy to hear from you. Doc, I have microscopic hematuria for the past 20 years. Every year I do urine culture and RE, and I will have positive blood, but under culture they don't find anything. Occasionally I do urine cytology and find no major findings. Last year, my CT scan showed stones, which was above or below 3 centimeters, and my doctor said it was very little. Why do I still have blood that is not visible in my urine? I am 65 years old. Can you comment on that briefly?
Yes.
Yeah.
So thank you very much. 65 years with blood in the urine. Obviously, you need to see your doctors for evaluation because it could be anything from malignancy to stones to any other.
But he is seeing his
commonly
doctors.
Infection. He's seen a urologist.
Yeah.
He's done a cytology. I'm sure he's done other procedures. They've not located any cancer, prostate, etc.
Okay.
But they found a stone. Now the stone. The 3 centimeters is big. I'm sure he's referring to 3 millimeters. That's probably what he's referring to.
He says the doctor
3
says
millimeters
it's
is small, so
right.
they'll observe it. And that stone can really cause blood in the urine. So it's the most likely cause of the blood in the urine. There are other causes of blood in the urine in the absence of stone, which again will need further investigation,
Okay.
even including histology or biopsy to define such
Right.
diagnosis.
Okay.
So if beyond this point he's still worried, then he still has to see his doctor for more explanation,
Okay.
or seek a second opinion to be sure that it's really due to the stone and no other cause.
Right. Okay. Great. See your doctor, have it checked up again, and seek a second opinion. Doc, does one need a referral to come to the nephrology unit?
If it's in Kolebu, yes, because Kolebu is a tertiary institution, it's a referral center. You need a referral from a polyclinic,
Okay.
and that's really not a big deal.
Okay.
And all the primary care physicians know that persistent hematuria, they would have to refer to
Okay.
a nephrologist for a further investigations
Okay.
and workup. So that shouldn't be a problem.
Okay,
Yes.
great. Now, the theme for our 60 years anniversary is building on 60 years of quality medical education, the role of technology. Now, we're looking at pinpointing and zeroing down on this diagnosis, right? Some of the things are pretty complicated and specialized. Over your years of experience, how have you harnessed, or what have you seen in terms of the harnessing of technology to actually zero down and help those afflicted by this condition?
So you mean those who have progressed to end stage?
Well,
Or-
generally across the stage,
So-
diagnosis, and then
Right. So I think over the years, for now, of course, diagnostic methods have improved
Right.
in Africa and the sub-region. So that may also be the reason why we are picking more and more cases, because in the past, probably the means of diagnosing this
Okay.
were not there. So now at least you're able to do all the blood tests
Okay.
to say there's derangement in kidney function.
All right.
You are able to look for underlying causes from the labs, including serological tests for autoimmune diseases,
Okay.
for other very rare diseases that you are looking for. You're able to do a kidney biopsy to really look at the histology to find
So
out
in
what
that,
is
in that
going
instance,
on.
you're taking a sample of kidney tissue.
Exactly,
for
and send
further-
it to the
right.
lab. And then you have all these CT scans, MRIs. We can tell you a lot more
Okay.
also about the kidney when you need it. And this really help you to arrive at some diagnosis that probably some decades ago you wouldn't be able to do that. So once you're able to do this, and nowadays as well, there are newer treatment
Right.
methods which are available, which you can really explore
Okay.
to try and help all these people. So yes, things look much better now compared to decades ago in terms of therapy,
Right.
in terms of diagnostics. Yes.
And I guess in terms of the facilities and resources available for training of these
Exactly.
specialists as well.
Absolutely.
All right, great
Yes.
start. 35 minutes already past the hour 2 on Joy 99.7 FM. You're listening to me, Nortey by nature, and I'm with a very, very good brother, but a specialist, nephrologist, Dr. Vincent Boima of the Kolebu Teaching Hospital and, of course, of the University of Ghana Medical School. We're looking at young but failing kidneys. What has caused this epidemiological shift where we are seeing the profile of cases shift downwards towards younger, more productive people? We've explained what kidney disease is. We've explained some of the key salient risk factors, especially for our part of the world and sub-region. If you have questions, concerns, my phone lines are active now, 0302 216-541, 0302-216-541, and you can speak to Dr. Boima yourself. I've got this on the screen. Somebody's sending me, I think, their lab results. But it says, Doctor, this is Adams Suraka. Doctor, I'm having blood in my urine, excruciating pain in my lower abdomen, and indigestion. I went to see a doctor, and he said I have infections. The thinking alone can kill me. For 12 days now, I see blood in my urine. They gave me medications, but I'm still scared. Adam Suraka shares that. Let me see if I can read a couple of more. Hello, in Ghana, it is called Sabai. This is from my in Teshi. Oh, in Ghana language, it's Sabai. Okay, so it's not Flufla. Right? I think Flufla is lungs. Right? Thank you. This one says, good afternoon, Norte. Kindly clarify, did the doctor say abuse of diclo can put someone at risk of kidney disease? If so, does using dicloacetaminophen and other pain meds indiscriminately, you've added the word indiscriminately, affect the kidney? Doc, quick one on that.
Absolutely. In fact, he just said it. Indiscriminate use is the problem.
All right.
Habitual abuse of these drugs is what we are talking about.
Okay.
If the doctor finds it indicated in prescribes it for a short period,
Right.
that's okay.
Okay.
But if you're buying it over the counter yourself all the time because of minor aches and pains,
Okay.
that is not advised.
Okay.
And I think the guy who said persistent hematuria
Yeah.
with lower abdominal pain, you really need to see
Suraka,
a
right.
doctor for workup, because if it's just an infection, you probably should respond to the antibiotic you've been given.
Okay.
Also, the doctor should have done a culture and urinary to find out if it's an infection or
Okay.
not. But if it's this is persistent beyond all these workup,
Okay.
you need to see a specialist for further evaluation.
Okay. Great stuff. I have a caller on the line. Hello.
Hello, good afternoon.
Good afternoon. Who am I speaking to? And where are you calling from?
I'm Samuel. I'm speaking from airport.
Okay. Go ahead, Samuel.
Please, if you drink pipe water, are you likely to get kidney problem?
If you drink tap water from the tap.
Tap water, pipe.
Okay.
Tap in the house.
Why do you
Is
ask
it
this?
likely? I've been drinking it a lot. That's why I'm asking.
Okay. Right. I can't speak to the quality of your tap water, but he's asking if you drink straight from the tap. Pipe water or tap water.
I don't think so. If the water is that purified,
Right.
and then goes through the right measures of purification, probably
Okay.
not the case.
All right.
But there have been, like I said, underground water.
Yeah.
So from the well, from
Okay.
other places where it's been shown in other countries that
Right.
well water, underground water.
So we should be
could-
concerned
we
about the
should be
quality of
concerned
water.
about
Right.
Quality of the water, whether it's been purified or not. But there's just a hard water which contains all the chemicals that you're drinking.
Right.
That's really what the problem
Okay.
is. Yes.
Great stuff. I have another caller on the line. Hello.
No, it's a good action.
Yes, good afternoon. Who am I speaking to, please?
Oti watching from Stella.
Oti, you're welcome. Please share with us quickly.
Thank you. I said action. Nowadays, I hear that they said herbal drugs gifting. Is that true? Or just people are just saying?
Okay. Herbal preparations, herbal drugs. He's asking, is it related?
Yeah, so I'll deal with this both acutely and chronically.
Okay.
So we have seen a lot of people in the hospital who have come down with acute kidney injury, which I defined earlier on.
Okay.
After having taken some herbs.
Right.
And then they come down not only with the acute kidney injury, but their red cells are breaking down, their urine is dark Coca-Cola, they become jaundice because of this, and
Right.
their kidneys shut down.
Okay.
That's a typical example of somebody taking herbs and developing acute kidney injury.
Okay.
Then there have been work in the sub-region associating chronic kidney disease with herbal medication.
Right.
From some work done by Tano, as you
Right,
read.
yes,
You
yeah.
read that, it tells you that there's an association between herbal medication and chronic kidney disease as well. However, that is an association and not causality per
Right.
se. So there's a lot more work needs to be done
Okay.
to really establish causal link
Okay.
to it. But with the upsurge of kidney disease in the sub-region, it's really an important thing that needs a lot of investigation.
Okay.
And we've heard from testimonies of our own patients who stopped taking the medications that we prescribe,
Right.
went after these other herbal solutions, homeopathic solutions,
All right.
and then within a year or two come down with having progressed to advanced stages of kidney
Okay.
disease or having lost their kidneys.
Right. So we need to
is-
investigate
function
this further.
completely.
But it's definitely an
Exactly.
associated
So
risk.
These are patient testimonies,
Right, okay.
which really means we need to take this seriously.
Okay, great. I have a caller. I think I have two callers on the line. Let's take them quickly. Hello, good afternoon.
Hello, good afternoon.
Right. Who am I speaking to and where are you calling from?
My name is Kwesi. I'm calling from Tema.
All right, Kwesi, share with us quickly.
Okay. I want to ask the doctor. I've been having very severe headaches. So I take a lot of Panadol extra. I don't know if you know that particular tablet.
Yeah, go ahead.
For some time now. Yeah, sometimes I even wake up with headaches, severe ones, and sometimes I don't have any choice but to take the drug. I want to know if it is harmful to the kidney.
All right. Let me take another caller. Hello. Hello, good afternoon.
Yeah, good afternoon,
Yeah,
Bobote.
your name and your location, please. And then go
Yeah,
ahead.
my name is Dennis. I'm calling from Legon.
Right, Dennis, you're welcome. Go ahead.
Yes. Yes. So I've been having these pains in my lower abdomen for some time now, for close to 2 years. And it gets really bad, and sometimes I end up on admission in the hospital, and they tell me it's kidney stones. I've done a lot of tests and scans and everything, and every time they just give me painkillers. And when I'm on admission, I think like it's so bad, I'm just giving more pain. But they seem I don't think to get any solution.
Okay. Right. So he's having pain. He's been told kidney stones for 2 years, and he's not getting relief. But the first caller is saying he gets frequent
Panadol.
headaches.
Yes,
And he
takes
resorts
Panadol.
to Panadol. And listening to us, I guess he's concerned.
Yes.
Now, we know headaches can be a symptom, right, of many things. But many people respond in this way. Doc, what can you say to that in relation
So
or
I
linkage?
think that having a persistent headache over a long time, you need to see a specialist for evaluation to find the underlying cause of the headache.
Okay.
Because there are two types of headache: a primary headache, which could be the migraine, cluster headache, or tension headache,
Right.
and the secondary cause, which can be due to any cause, just like you are saying.
Right.
So this patient needs to be evaluated by the physicians carefully, find out what the cause of the headache is,
Okay.
rather than abusing Panadol all the time because he's having headache. That's really not right. So
Okay.
you need to see the doctors. If it's migraine, then of course there are long-term treatments that you can be given,
Okay.
etc.
Right. And this chap who's just shared with us kindly that he's been diagnosed with kidney stones. They give him painkillers and all sorts of things. He's not getting relief for 2 years standing now. What should he do?
Has he seen a specialist? That's the question. The person
How do you
who-
know if you're seeing a specialist? You've
So-
gone to the doctor or a
so-
health facility and this is what they have
Right.
told
I
you.
said that I was a nephrologist. I take care of kidney diseases.
That's right.
From the physician point of view.
Okay.
But we have surgeons who take care of the genitourinary system or kidneys from the surgical point of view. They are
Right.
called the urologists.
Urologists,
So
right.
they see these people and evaluate them and find out whether the stone is something they have to treat or
Okay.
remove, or there's another cause of this pain, etc.
All right.
And if it's among these urologists, there are some who have specialists actually in stones,
Okay.
whose only work is stones.
All right.
And these are the people that this guy needs to see.
Okay.
So they would really evaluate him and find out what the cause is and give him an appropriate treatment that will relieve his pain or take the stone away.
All right. This is most revealing. We're talking about young but failing kidneys, but we have gone wider and more comprehensive to explain what kidney disease is, how it is diagnosed, the risk factors, what could be fueling or accounting for the numbers of younger presentations. Many of them, Dr. Boyma suggests to us, are in advanced stages. Our phone lines are active, 0302-216-541, Ultimate Health on Joy 99.7 FM. Now, my Ghana people, Maba, Mini Sunny. Now I'm getting another Ghana name. I need to have a Ghana conference on kidneys, right? Yeah. This one says it is called Tabo in Ghana. And then the person goes on, good afternoon, Nortey. The doctor got it right on lack of proper data to lack of proper data keeping, because my 6-year-old daughter suffers kidney problem or suffered it last quarter of 2021. So the prevalence rate can't be from 20 years. No, he talked about the actual, should I say, the mean age group, yes, right? He's not saying you can't have it at a lower or younger age, right?
Children also develop kidney disease.
Right.
In fact, we see quite a lot. That's why we have pediatric nephrologist.
Right. Okay.
Yes.
And he's Nana Kwesi Ofori from English Amamfro. Nana, listen to us carefully. Thanks for your contribution. He did not say you can't get it at younger ages, right? Indeed, some are born with kidney malformations and other things, exactly, right? And that is why we have pediatric nephrologist as well. Thanks for sharing. You can share your 055 1111 997 Ultimate Health on Joy 99.7 of goodness. Good afternoon, Norte. This is what does it say? Oh, right. And your guest, please, is allergy or are allergy conditions a sign of kidney or liver problems? This is from Fifi in Kokomemle, Doc. Hang on to that. Richmond from Awoshi, Doc. I've been drinking a lot of alkaline water. Is it good for my system? Whoa. Is alkaline another one? Alkaline water the best water? This is from Kofi in Accra. What else do I have? Somebody has added their lab report. This is the person who has had said for the past 12 days blood or in their urine, right? And you suggested that this is Adam's Suraka.
You can see a nephrologist, you can see a urologist, you can see.
All right. Doc, on the heels of that, we've mentioned referral. Yes. Is there a number to call for the unit, or because it's
a referral center?
Right.
So the best place to go to is the polyclinic and get a referral.
Okay.
And then yes.
All right. Great stuff. Let me clear these others. Norte, I like taking F-Pack when I have headaches. Can it have any effect on the kidney? Today is confession time. This is Michael Komla. F-Pack.
So
Right.
FPAC, I think the component is largely paracetamol.
Paracetamol, acetaminophen. Yeah.
And so if it's really paracetamol alone,
Mm-hmm.
then the effects are minor. Now, if you have paracetamol overdose,
Mm-hmm.
that is when your risk of developing kidney disease increases.
Okay.
But within the right dosage range, the risk is small or low.
Okay, right. Okie dokie. You're hearing that from my specialist in the studio, Dr. Vincent Boima of the University of Ghana Medical School, head of nephrology unit at the Department of Medicine and Therapeutics, Kolebu Teaching Hospital. Right. My phone line is still active. This one from Dede in Maryland. Dede, I believe last week was your birthday. Many happy returns. She says, can one be born with one kidney? Can you be born with only one kidney? If yes, does it function as well as having the two?
Yes.
And second question, managing hypertension, diabetes, cholesterol, etc., and its related diseases with medicines inadvertently causes kidney disease, meaning managing one problem causes another. So is this the catch-22, right? It does mean you should be seeing the right people.
Yes,
Right.
exactly.
Mm-hmm.
So with the first one, you can be born with one kidney. In fact, there are a lot of people quite a number of people are born with one kidney, and they function normally. Their kidney functions actually may be almost normal, and you may not even know that they have one kidney until incidentally,
Right.
you're going to do some other tests, a scan for another thing, and they find out that all these years they've been living with one kidney. In fact, I've seen a couple of them,
Right.
and their kidney functions are almost near normal.
Okay.
So yes, it's all because from birth one kidney did not develop at all.
Okay.
Or along the line, the other kidney suffers some kind of disease and then shrink along
Right.
the line,
Okay.
etc. So there could be kidney agenesis from
Right.
birth,
Okay.
which the person had been living on one all this while,
Right.
and until now. So yes,
Okay.
everybody can live on one kidney,
Right. Okay.
and that's the principle with which we do kidney transplant,
Yeah, transplant
whereby
and
people
donation.
can donate one of their kidneys
Right.
to another person.
Okay. Hang on to the question on alkaline water. I have a caller on the line. Hello, good afternoon.
Hello, good afternoon.
Good afternoon. My first lady, your name and where you're calling from, please.
My name is Florence Ashai. I'm calling from Boom.
Right, Florence, you're most welcome. Share with us.
Yeah, I was a CKD from 2014 to 2020. I had a transplant. But after the transplant, I realized that I was losing weight and not having a lot of chest pain. I want to find out from Dr. Waima what could be the problem. Because
Right.
all the tests that I did about a month ago shows that everything is working perfectly.
Okay.
Thank you.
So you were treated for 6 years with chronic kidney disease. Then you had a transplant.
Yes,
Everything's been okay, but you are losing weight.
yes, sir.
All right. So you want to know why?
Yes, sir.
Okay. Doc, I don't know whether you heard that. She was treated for 6 years for CKD, successfully had a transplant. She's been fine, but she's losing weight.
Yes, so I
She's
think
concerned.
she has to come to the hospital, the transplant clinic, for evaluation. Our transplant clinics are usually on Fridays at Kolebu Teaching Hospital.
Okay.
Because transplant has complications as well,
Right.
based on the immunosuppression, and therefore you need to be evaluated for the weight loss. It's very, very important, and I will encourage her
All
to
right.
come to the clinic so we find out the reason why she's losing weight, because there could be an underlying cause
All right.
due to the immunosuppression.
Okay, great. All right, Nortey, this is Alex from Botre. Is itching a sign of kidney disease? Itching. Doc.
In fact, this is why I'll take my time to say that chronic kidney disease is largely very silent from the early stages. That is why you said earlier on there are many people walking out there
That's
not
right.
knowing that they have kidney disease because they feel well and they don't see the reason why they should go to the hospital.
Right.
So they wait until they start feeling unwell. At that stage, it's well advanced in stage 4 or 5.
Okay.
Now, so to have all these symptoms of itching and the others, it means it has progressed to advanced stages.
So you are confirming that it's related or
Yes,
could be related?
it's a symptom.
Right. Of course, you
Of-
could itch for other reasons.
Yes, of course.
Right.
So it's a symptom of accumulation of this waste product due to advanced kidney failure.
Okay.
But pruritus or itching can be seen in other conditions.
All right, so it needs to be investigated. Right, great stuff. For 51 minutes past the hour of 2 on Joy 99.7 FM. This is really, 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 really revealing and transforming, if I can say so. This is, all right. second question related to, I think we had hinted to it earlier. Dede was saying the management of these diseases or conditions, hypertension, diabetes, and so on and so forth, could also cause or the improper management. Right.
So that's why it is very important for you, especially those in a high risk group. If you have family history of diabetes,
Right.
hypertension, you need to screen and detect this early,
Okay.
so that they could be controlled to prevent the development of kidney disease.
Okay.
Or if you have them, take your medications regularly,
Right.
so that the numbers will be kept under control in target range,
All right.
to prevent the development of chronic kidney disease.
Okie dokie. Right, it's 52 minutes past the hour of 2. Please, I've been taking Oxafen for my menstrual pains. Should I be concerned? This is from Dede.
Oxafen looks
In
like
that-
ibuprofen or brufen,
Right,
I guess.
yeah.
And regular intake really increases your risk of developing kidney disease.
But if it is linked or it's addressing menstrual pain, then it's likely to
you
be
need to
regular.
see your doctor for a change in
Okay.
the pain medication. Because
Right.
a constant abuse of this can increase your risk of kidney disease.
Wow, my word. Young but failing kidneys. It's a big topic. We haven't even gotten to staging your kidney disease and all those specialized bits of information, but it's been very revealing. We're fast running out of time. I've read this, the Oxafen, okay? The alkaline water, yes.
So the alkaline water, we give alkaline medications all the time to treat, for instance, to prevent the development of stones.
Right.
From some retractable urinary tract infections.
Okay.
To treat acid-based problem, acidosis or accumulation of acid in the body.
Right.
We do that, so it's used and it's largely safe. But it does not mean that you should be abusing it on your own constantly because of these things. It needs to be prescribed by a doctor based on specific indications.
Right.
So I don't think that going about taking and drinking it is really the best way of doing it, but they should be given on specific indications.
Right. Now, Doc, a lot of these in the minds of many people are over-the-counter medications, right? And they are able to grab them even if they are not over-the-counter. Can you give us a word on that, your concern on that? The fact that I can go into a pharmacy and literally procure anything. Is that part of our problem that, as we discussed?
I think it's part of the problem.
Right.
There are drugs that I think the Food and Drug Authority regulates, and I think that
all these NSAIDs and
I think
ibuprofen
that,
and so
yes,
on.
there should be some policy regarding the usage of these drugs. I'm not sure what FDA would want to do.
Okay.
But if really we are having a high burden of kidney disease and some of these things are of a concern, then probably what FDA is doing now may not be adequate. They need to take a second look at how to regulate the usage of these by the public. And in essence, maybe be able to make it a prescription drug. I'm not sure whether that is right or not, but FDA can have a second look at that so we can protect our citizens.
All right. Careful what you're taking, how you're taking it, and why you're taking it. And make sure you are seeing the requisite professional with the requisite training and expertise. Please, Doc, how true is it? Here it comes again from Dagati in DC, Petroleum. Intake of coffee and kidney disease.
So there's no real direct link between the coffee and kidney disease per se. You can talk about coffee and some heart conditions like dysrhythmias. Maybe if probably it precipitates heart failure.
Right.
Heart failure can, of course, affect the kidney and cause kidney dysfunction.
Okay.
That's an indirect route, but that's probably the link that I can create now. But when you read literature, really, there is no direct link between coffee per se and kidney disease. You see a lot of things online as risk factors of kidney disease, but it may not really be the case.
Okay, right. This one from Kojo in Takra, they're bringing in at the last minute GFR of 83.7. This is a measure of your kidney's ability to filter.
Yes.
Right. I don't know whether you can give a brief.
So that means that his kidneys are washing 83 mils of the blood every minute.
Okay.
That's what it means.
Right.
And that's really above 60. If this 83 is not accompanied by protein or blood in the urine, it could be considered as normal.
Okay. Right. Those are things we'll have to beg. Doc, Is it possible for us to grab you next week so that we finish
sure.
this? I think this is very, very critical and serious.
I think so. We can do
yeah,
it,
so
yes.
that we look at all the stages of kidney disease and the management or available management, right? But Doc, let's end on this one. When it gets to chronic degree, right? Does it have a cure?
Chronic kidney disease does not have a cure. It's more or less a one-way traffic. It will surely progress to the end.
Right.
So it starts from early stages, stage 1, stage 2, stage 3,
All right.
stage 4, stage 5, which is the end stage. That means your GFR, as the caller said, is less than 15 mils per minute, which means that at that stage, your kidneys are only able to wash less than 15 mils of your blood per minute, meaning that it's not washing enough, so the toxins will accumulate.
Okay.
So surely chronic kidney disease will progress to end stage. There's no cure.
Right. So
that's
what we're
why
doing
we
is
hammer on
manage.
early detection.
Right.
We hammer on early detection. We hammer on detection of the risk factors even earlier, so you can prevent it.
Okay.
But if you develop the kidney disease, it must be detected early to put in measures to delay how fast it progresses to end stage.
Whoa.
So if you do nothing, it may take 4 years to progress to end stage. But if you hold all the risk factors in check, it may take 10, 15 years to get to end stage.
Okay.
So that's really what you do.
Okay.
But surely it will progress.
Okay, great stuff. 58 minutes past the hour of 2. It's been, should I say, lightning speed revelations on kidney function and kidney disease. I guess by now we're appreciating and understanding why we'll have younger people, especially in our part of the world, presenting with kidney disease. I'm most grateful to Dr. Vincent Boima, senior lecturer and consultant nephrologist and head of the nephrology unit of the Department of Medicine and Therapeutics of the Kolebu Teaching Hospital. He's here on account of the University of Ghana's 60th anniversary celebrations, and he has agreed kindly to join us next week. We'll look at dialysis, we'll look at the stages of the disease, we'll look at the options for treatment and management. And I can assure you it will also be very, very revealing. Many thanks once again, Dr. Vincent Boima, and many thanks to you, my listeners. I've seen a couple of things I could not read out, but we're out of time. We'll be back next week on Young But Failing Kidneys. Stick and stay on Joy 99.7 FM. Up next is my brother Bile. He brings you Sunday Rhythms. Many thanks again to my producer Abeku Sankofi. Stick and stay. My name is Nortey by nature. I'm out.